Okay, Lauren, if you wouldn't mind starting the recording, I think we'll get started with the webinar.
We're good.
All right, thank you. Hi, everyone. This is Kate Myers, and want to thank you all on behalf of CHCS for attending our webinar today. We're really excited to have Dr. Dana Lustbader from ProHealth in New York join us today. And just to give a little context of why we invited her here today, we were thinking back to our March meeting, our in-person meeting, and feedback from that meeting, where a lot of people continued to express interest in learning more about telemedicine models and opportunities for being efficient with staff time and the opportunity that telemedicine affords for that, and just generally continued interest in learning about other innovative care delivery models that are being implemented around the country. And Kathleen Kerr heard Dr. Lustbader speak at the AHPM conference a few months back and said, this is a model that our group would love to hear about. As you'll hear from Dr. Lustbader, ProHealth's model includes home visits, telemedicine opportunities, use of volunteers, as well as very deliberate caregiver support activities. And we thought this would be a great thing to learn about for you guys to ask questions of and share observations about your own experiences, either in the home setting or in attempting to use telemedicine, or questions about any of those aspects. A few logistical things before we introduce Dr. Lustbader. This webinar is being recorded, so those who weren't able to attend today will be able to listen and see. We'll be sharing the slides and the recording within a couple of days. It usually takes a bit of time to process it and get it on CHCS Dropbox account. So that stuff will be made available, and I'll send an email out to all the payer provider teams with that information. So it looks like we have a good group on today. We'll have Dr. Lustbader present, and then we'll have opportunity for questions, either through the question box or by raising your hand after the presentation. So we'll get started in just a minute. So in the way of introduction, Dr. Dana Lustbader is chair of the Department of Palliative Care at ProHealth in New York. She's also a critical care physician and was ICU medical director at Northwell Health. She's a clinical professor of medicine at Hofstra School of Medicine, and she's triple board certified in internal medicine, palliative care, and critical care medicine. We're very excited to have you here today, Dr. Lustbader. So with that, I'll hand it over to you to review your presentation.
Great, thank you so much, and good afternoon, everyone. It's a pleasure to be here. Today I'm going to be talking about home-based palliative care within the context of a Medicare Shared Savings Program, ACO, which we have here at ProHealth. I'm just going to advance here. And as everybody knows, and I know many on this call are doing home-based palliative care already, but I always like to just start with the usual care, which we've all seen with the 3 calls to 911 in a few months, 3 admits, tremendous family distress, as opposed to home-based palliative care, and we actually call our program ProHEALTH Care Support, which is 24/7 access. We do telemedicine or virtual visits with family members as well as patients. We support the family caregivers, and we certainly don't routinely say go to the ER in our voicemail. In fact, there is no voicemail, but we don't have a voicemail that at 5:30 p.m. says go to the ER. We actually answer the call or do a virtual visit. So ProHealth Care Support is part of ProHealth, which is a large multi-specialty physician group in the New York metropolitan area, and we have about 900 physicians serving about 1 million patients. But within that space is a Medicare Shared Savings Program, ACO, where we serve about 32,000 beneficiaries. And we're largely a fee-for-service organization, very little Medicare Advantage here, although we do have a number of shared savings programs that we partner with other health plans with. So, but we're primarily fee-for-service, but our sweet spot for innovation is in the Medicare Shared Savings Program, ACO, and we've been doing that for about 3 years now. So in terms of what I'm going to cover today, I'm going to talk a little bit about our program, the staffing model. I'm going to go into some use cases for telepalliative care. I'll talk about how we use volunteers and how we identify patients, and then just a couple of ways we get paid for doing home-based palliative care. And just what I want to call your attention to on the right is this is our folder, and we've been very careful how we brand ourselves, so we are just an extra layer of support at home. The phone number on the front and on the magnet, that little square thing below, actually goes right on the fridge. And then we give them a pen that also has that same phone number. that's pretty much what we tell people. And in fact, we do answer that 24/7. Administrative staff answer it in the day, and then it's triaged to a physician or a nurse at off hours. So it's always answered warmly. On the inside of the folder is just blank paper and a pen for people to write questions down. We noticed when we went into people's homes that we were tripping over these folders, and they were often unread or too complicated. So this is really simple. Call us. We're here for you, and we answer 24/7. We're a high-touch model. So what I mean by that is it's a house calls program with RNs, social workers, and docs, and other folks as well, our volunteers. But the touches can be in person, using telemedicine, using the telephone. Different levels of providers can reach out and check in on patients. So our front desk staff have a list of patients we're worried about, and they might call those patients once a week. So Maria, our secretary, has a list of about 20 patients that she calls, and that's just an extra touch point for these patients. Just how are they doing? Is there anything you want me to tell your nurse or doctor? And then we do have about a cadence of once a month in the home where the RN actually makes a house call. There's telephone support. Our volunteer department is made up of community folks. We have 12 people in our community. We get more in the summer because of an influx of college students. So they're in service by our social workers, and they will make friendly visits. Many of our volunteers are professionals. They work during the day, but they have other interests like Reiki massage or sharing a meal with a patient or hearing stories. So we schedule them to meet with patients in the communities that they live in, and they become part of our team. And they join our team meeting once a month, so they feel a part of the team. They sign all of the appropriate disclosures so that they can be part of the team. And then they and the patient actually schedule the visits on a frequency that works for both of them. The program is a 24/7 availability. So again, we either answer the phone or we'll do a telemedicine visit with patients 24/7 so that there's always availability. There's never just a direct into a voicemail after hours. The staffing model is an RN social worker model. Each RN has about 85 to 90 patients. And so the model really is one MD, one social worker, and 3 nurses for about 300 patients. And we have 2 pods, so we have about 600 patients in our census on average. And the team meets once a week, 1 hour twice a week on Tuesdays and Fridays. And then we have a once a week RN MD one-to-one where the physician will run the list with the RN. And during those meetings, we will loop back with the patient's other doctors. So we're very mindful of making sure we don't steal patients or leave anyone who wants to be involved out. But many of the patients that we are seeing are becoming more frail and homebound, and it's difficult to get into the office. And also in our area, they have multiple subspecialists, none of whom speak to one another. So this care coordination that occurs during the one-to-one is really important because sometimes the primary care doc may not know the patient has seen 3 or 4 other specialists or what has been prescribed. So we really try to keep the primary care physician engaged or involved if they want to or if the patient has one. And that's what we do during the one-to-one. And in fact, if the patient still gets into the physician's office, we support that and try to help them get rides there until that becomes too burdensome for the patient and family. So our use of telemedicine has many advantages. It allows us to have a physician or social worker in the office and to cover a very large census of patients. We can also see what's going on so that if one of our nurses is in the home and is worried about something, we can have a visit with the nurse or even a home health aide or a family member to see what's going on. I always love it when my nurse takes and we use standard devices, people's own cell phones, so we use people's smartphones, and they download software that's HIPAA compliant, and that is how we do it. So it's very similar to FaceTime, but it's a HIPAA secure technology. And the platform that we happen to use is Video, VIDYO, but there are others like Zoom or Skype for Business that can be used as well. So the nurse will scan the room or the fridge and give us a real picture of exactly the kind of environment that the patient is living in. So if they're a hoarder or there's no food in the fridge or they're really having trouble getting down some stairs, they'll show us the entire living situation. So that environmental screen is really useful, and it's something that you don't get with a phone call. There's also a lot of satisfaction. Our patients really like seeing the doctor. And we have a lovely little 90-year-old couple that once a month I will do a virtual visit with when my nurse is there. And the wife will put on her lipstick and change her house coat because she's seeing the doctor. And it still has a lot of value to them that they're actually seeing a doctor who's part of the team. So there's tremendous family satisfaction knowing that there are other members of the team thinking about their care. The disadvantage is the technical difficulty that many people have downloading an app because it is HIPAA secure. They've got to go and figure out how to download a free app so that we can invite them into our room. And so many older people have difficulty doing it, although we do rely on their children and grandchildren to help, or their caregivers, paid or family caregivers, who can do it as well. And then we sometimes have connectivity issues near the water, particularly in parts of Long Island where we're really just struggling to get connection. So we sometimes have that issue. But the nice part about the technology that we use is you don't need other devices. It's just right on the patient's iPad, laptop, or smartphone. So we're not putting other technology into the home. So the way that we use telemedicine in our home-based palliative care program are outlined here, and I'll give you some examples of these. I think most commonly we use it for acute issues. Something has come up, or we're worried about how somebody is looking, or a rash, or something in someone's eye, or there's an infected foot, and we can really get a sense of how we want to treat something by looking at an issue like that. And the second way is to arrange family meetings for advanced care planning so that when family members are spread across the country or the world, we can have up to 20 people in our virtual room, and then the little heads just float around the iPad or laptop or iPhone that people are using, and whoever's talking, their head pops to the top. So here's an example of an acute issue. This is 5 p.m., and this is a woman who was on Coumadin, and she called her doc because she had fallen and she got stuck behind the toilet in her bathroom, and we were just worried about her because she was anticoagulated, and we could really do an immediate assessment of her after she fell. Right away I could see her, and this is us. I'm in my office, and she's actually in her home at the table, and we're doing a visit, and we can really screen her. And then I can send my nurse out to follow up the next morning because I can really see that she's back to her baseline, and we can just check things out then, and the nurse can go back the next day. So we can get a real visual of how she's doing post an acute issue. An example of advanced care planning, this is a MOLST right on the fridge here, but this is a family meeting that we had with the patient's family members scattered about, and we could include everybody on the phone for this discussion where we document the DNR and don't hospitalize preference so that we could complete that family meeting using telemedicine with the patient in her home here at the kitchen table, but the other family members were scattered around. And that works very nicely. Family members like being included in that way. This is a follow-up visit. So this is my nurse, Andrea, who's in this patient's home, and I'm in my office. And we're following up on a recent skin biopsy that she had that had gotten infected. And so it allows us to use our ends in the field with medical support so that we can manage things like this together. But it can also just be a scheduled follow-up visit as well, where a physician can just come in, or a social worker. Sometimes families want to have a discussion with one of our social workers who's covering 300 patients, and so instead of sending the social worker out, we can just do a virtual visit, and that social worker can answer the family questions or loop in all of the family members if they're trying to figure out how to get a Medicaid application completed, or to privately hire home health aides, or to figure out how to get rides to the doctor. So the social worker can coordinate a family meeting or a visit with the patient using the telemedicine, and it's much more effective that way. It really just seems to make it more personal, and she can see the reactions of folks and get a better sense of what's going on with the family. This is one of my regular patients. She has multiple sclerosis, and so she just throws her phone down by her feet in the wheelchair, and we can have a visit every 3 months and really just continue to build trust and a relationship. Even though my nurses are out in the field, she and I have a tight bond through telemedicine because I see her frequently, and she likes knowing there's a physician there. And when she does have an issue, I can see whether there's been a clinical change or not because I actually know her. And she also knows that we're here for her. So it really does build trust that she will use this number rather than calling 911 for an emergency. And we can often troubleshoot for her because it's difficult for her to get out. For Medicare Advantage, as of January, it does appear that you can code for telemedicine, although there's no payment for it. One can code for it and include the visit code and the telemedicine code and capture other chronic conditions that might have been missed. So here's an example of a woman that my nurse and I are seeing. We're both in the office. The family member is showing us this blood blister on the patient's leg that's actually getting better, but we could also code for things that might have been missed, like cachexia or protein calorie malnutrition or other things. And that carries over into the following year for Medicare Advantage. So for risk-adjusted factor coding or RAF, that has significant monetary value to Medicare Advantage plans. And this is our team meeting. This is our Good Morning Monday call, and we do this virtually. We have team meetings in person Tuesdays and Fridays, but our Good Morning Monday call is done virtually. So again, you can see that there are multiple heads that float around, and you can hold up to 20 people in a room like this, and we have here about 7 or 8 of us floating around, and whoever's speaking floats to the top. But it really is helpful for team wellness, and it allows us to sort of make jokes or see how messy someone's car might be, because we're a mobile workforce and everybody's out in the field, or if somebody's taking the call from home, and it really does build team wellness. It also allows us Monday morning to debrief on all of the calls that have come in over the weekend, so that Monday folks can take care of those issues right away Monday morning before they start their day seeing patients. So that is a great way for us to have team meeting, and then we do in-person teams on Tuesday and Friday. And this is supporting family members and patients during dying. Sometimes patients are not eligible for hospice. Our large physician multi-specialty group does not own hospices or home health agencies. We're just a physician group of 900 physicians doing outpatient care and ambulatory surgery centers, but we don't have home health or hospice. We do refer to hospice quite a bit, and we do partner with many home health agencies in our area, but sometimes we have patients in our program that are never eligible for hospice because they don't want to forego treatments, or they don't have a certifiable diagnosis, so they die in our program. And we can provide a lot of family support during dying. My nurse is here with this family. This is a caregiver that's been with the patient 9 years and a daughter, and my nurse Joanne is with them as well. And it's very useful in reassuring families, especially if the physician or someone else can't be there, that we can see how comfortable the patient looks, and we can normalize the breathing pattern, and that the patient is so lucky to have these people in her life so that she can die at home so peacefully in her bed. And to really follow up on calls like this. So for something like this, I might call every hour, every 2 hours until the patient dies, to really make the family feel supported, even though we don't have the staff or ability to send physicians and nurses to be there for the next few hours. But we can certainly provide them support and encouragement that they're doing a good job, or give them guidance on how to manage certain symptoms like dyspnea if things are not going well. So the way that we leverage telemedicine is really availability. We can also plan ahead for any kind of things that might occur in the future with advanced illness. And then if there's anyone that we're very worried about on Friday or before a holiday, we'll do a tuck-in virtual visit with our highest risk patients just to make sure on Friday that everything is going well. Do we need any medications in the home? We actually anticipate any problems that might come up on a holiday weekend or something else using a virtual visit or telephone call, but ideally it's done with a virtual visit because then we can really make sure things are going well. And again, that's only for our highest risk patients that we do the tuck-in on Friday. In terms of the main diagnoses that we have in our home-based palliative care program, again, I mentioned we have about 600 patients. The average length of stay in our program is about 5 months. The diagnoses, cardiac being very common, but also dementia and frailty being very, very common as well. So this is what our distribution looks like in the population that we serve. Only about 20% cancer. Again, it's a Medicare population. In our commercial population, it's almost 75% cancer, 25% other. So this is a Medicare population that we're serving in the Medicare Shared Savings ACO. The way that we identify patients in our ACO, again, there are about 440 or so ACOs nationally, Medicare Shared Savings ACOs, and we get the claims data regularly, and we have an algorithm that looks for the top 5% patients, so we can look for high spend patients in the algorithm, but only about half of those have palliative care needs. The other half might have had a high spend and it's over, or they have no unmet palliative care needs, and really we wouldn't be appropriate to be servicing them. So this helps us to at least look at these folks first, but then we need to slice that further by diagnosis. So we start to look for other things that identify functional decline and frailty. So we'll look for HCC codes like metastatic cancer. We'll look for some things related to DME orders, so we'll look for home oxygen or a hospital bed or a wheelchair. So some of those things will be very useful to help us identify folks with progressive frailty. The other thing that we look at is admissions per thousand, and we do have a relationship with another health plan where we have a per member per month rate that they pay us for caring for their sickest patients. So they give us a prospective risk score, which is very useful in helping to identify the sickest patients likely to benefit from home-based palliative care. And we also, again, on that list, as well as within our ACO, look for admissions per thousand. So folks that have had 2,000 or 3,000 admissions per thousand, we'll start to seek those out, or people that have had 2 admissions in the prior 6 months, or age over 85 with 2 admissions or ER visits. So we start to slice our data looking for things like that, but we still have to do a telephonic screen because those methods are not perfect, and we really don't want to send folks to the home and fragment care further if they're already well cared for in their current arrangement. And we do look at future risk scores. Some of our health plans provide us with those. Those are the health plans that we're in a shared savings arrangement with. We have found that the sweet spot for our home-based palliative care program really is a group of patients for whom there's about a 25 to 50% one-year mortality. It turns out for people that we've had in the program for more than a year or going on 2 years, it's costly to deliver this kind of care, sending nurses to people's homes once a month, being available 24/7, having social workers involved. And it turns out that many of these patients could perhaps be served by other means like centralized case management programs. And we do have a centralized case management department where we will every quarter review our entire census. And we call it weeding the garden. And we'll weed the garden every quarter, and we'll look at patients that really are not truly homebound. They are getting out to all their other doctors. They're going to the beauty parlor. They're going to restaurants. We got them. Our screening is not perfect, or perhaps they've actually gotten better in the program, but we're really not adding value. And so we will either discharge them back to usual care, or we will triage them to a case management nurse practitioner who will stay on top of them, and if things change, they'll be re-referred immediately back to the home-based palliative care program. One of the things we use to supplement the claims data is an enrollment tool, and this is something that our front staff folks use when they are making a call. So once we identify patients from the claims data, the front desk staff will ask questions when they call. Hi, it's Maria. I'm calling from ProHealth. We work with Dr. Cohen's office, and he wanted to see if you'd be interested in having one of his nurses come to the house to check in on you. Just want to ask you a few questions first. And we'll know some of the answers here, like age and how many admissions they've had recently and their recent hospital length of stay and their cancer diagnosis. But we'll ask them more questions about how they get around the house. Do they use a walker or anything to get around? When's the last time they got out? Who do they live with? And we'll try to score them. And it does turn out this seems to be a fairly reliable tool. We're testing it now. We've been using it for about 6 months. And scores of 3 and greater seem to identify fairly accurately people that could benefit from home-based PAL care once we slice the data already to identify the highest spend or frequent admits. And then what we do every quarter is a strategic disenrollment process so that we don't keep people in the program who are not benefiting. And so we'll go through this. If they see many doctors, they're not limited with their ADLs. They're getting out to the hairdresser and to the kosher deli down the block, and they haven't been in the hospital or ER in the past 6 months. We'll consider disenrollment. And again, this is left up to the discretion of the nurse, but we really try to make sure we don't have people in program for more than a year or 2 years. We really want to try and disenroll them if they're not benefiting. In terms of patient satisfaction, we do a telephone survey of patients in the program after the 3rd visit, and we ask them 3 questions. Would you recommend ProHEALTH Care Support to your family and friends? And this is one of the surveys here of 50 patients that we just surveyed from one of our partner health plans. And then we ask them to rate the program on a scale of 1 to 10. And then we ask them why they rated the program this way. So really very simple 3-question survey, usually after the 3rd visit. And this is done by telephonically by the front desk staff or people that they actually don't know, so not anyone from the program. But people are pretty happy with the program. And in fact, the hardest part is actually when we have to disenroll people. They certainly are not happy about that. And we're making a very big effort now to not enroll people that we think we may have to eventually disenroll. So we don't want to be the cause of more fragmentation. So we're very mindful of that. And so in terms of how we pay for our home-based palliative care program, we are in a fee-for-service world, so we are mindful of billing when a physician goes to the house to make a house call or when we do advanced care planning. So we do bill on things that are billable. We cannot bill, at least right now, for RN visits or social work visits. And we do share in savings with several health plans. So when we do reduce the medical loss ratio or reduce hospital admissions per 1,000 or achieve certain satisfaction outcomes and quality metrics, we do share in the savings with health plans. So those savings go back into funneling our home-based palliative care program. We do have a per member per month rate with a health plan for their highest need patients, and that's per engaged member. So that's an established rate we've set with the health plan. And then it does appear that with Medicare Advantage plans, through risk-adjusted factor coding, one can improve the RAF score through more accurate coding, which would take effect in the following calendar year. RAF goes into determining the payment to Medicare Advantage members this year, but it impacts the payment for the following calendar year. So this is an example of something in our electronic medical record for advanced care planning. And this is that new code 99497. And what we did is we just modeled this after the Serious Illness Communication Guide from Susan Block and Rachel Bernanke at the Ariadne Institute in Boston with Atul Gawande's work. And we took the Serious Illness Guide, which is an excellent framework for conversation about preferences for care. We just embedded it into our electronic record. So it helps create a framework for discussion, and by checking these boxes, it actually creates sentences that actually populates a note. And so it does allow us to have a structured conversation that we think is better than usual care, and it allows this to be documented and captured in the medical record, and then it allows us to code and bill for it as well. This is an example of, this is our results regarding where our patients die who are enrolled in our program. So just for those that have died in the past 12 months or so, 197 have died. 85% were actually at home, either with us or with hospice. And we have about a 56% hospice referral rate. The rest actually die with us. And then those that died in the hospital. So very high likelihood of dying at home. In our market, only 25% of people actually die at home in the New York area, so 85% is really quite huge. The other thing is we have a 500% increase in median hospice length of stay. So for those we do refer to hospice from our program, they're in it much longer than usual care. And we do, through our QA process, look at any patient enrolled in hospice who was in hospice less than 30 days to see what happened. Were we the cause of a delay, or was it just a late referral to our program? But we certainly don't want to be the cause of any delayed referral to hospice care. So every team meeting, both Tuesday and Friday, an agenda item is who can go to hospice and who's eligible. And we have very good hospice partners, so we're very active in getting those folks enrolled if they are eligible. So our data has shown that in our Medicare Shared Savings Program, ACO, home-based palliative care was associated with a very significant reduction in spend in the final month of life and compared to usual care. And that includes the hospice care because it's a Medicare Shared Savings Program fee-for-service claims database we look at. So it's not like Medicare Advantage where hospice enrollment is a carve-out. So the spend of $8,200 includes that $5,000 or $6,000 of hospice spend, and it's still less than usual care. And again, the location of death is home for 85% of our decedents. And this is a slide showing the overall outcome in 2015 of the impact of our program. And the top line here shows usual care. So that gray line is just usual care of people who died in our Medicare Shared Savings ACO during the calendar year of 2015. The red line shows those that were enrolled in home-based palliative care and their spend. So this is everybody who died in the program here, and this is everyone who died within the ACO. And you can see the significant cost savings. And we also just wanted to take a peek at what happens if they die, palliative care folks. With hospice is the green line, and without hospice is the yellow line, so that we can see that with and without hospice, that spend. And then the red line really just even keeping that down with just home-based palliative care and not an enrollment in hospice, that spend being kept down. And that's largely driven by a reduction in hospital admissions, 43% reduction, obviously reduction in hospital length of stay and days. And then those that were hospitalized in their final month of life, way down. So again, early anticipation of what is progressing, serious illness conversation happening on the couch with the family and the nurse and the social worker, and good planning for end-of-life care. And that's the median number of days enrolled for this population. And then that hospice length of stay increasing quite a bit after enrollment in our home-based palliative care program, that we get those over to hospice quickly, and they're in hospice a much longer amount of time than those for usual care. We're going to open it up now to questions.
Great. Thank you so much, Dr. Lustbader. That was just fantastic information. So at this point, if folks have questions or observations or want to share stories from your own experiences, you are welcome to either use the raise my hand function, and I'll unmute your line, which I always like because you can ask your question yourself and phrase it just right. Or you're welcome to type it into the question box, and I will take a look at that and type this for you. Okay, we have one raised hand from Deborah Murr, so I'm going to unmute your line. It'll take just a second. All right, Deborah, you should be unmuted now. Deborah Murr, did you have a question? Let's see, it looks like she's logged in on the computer and audio, so hold on one second. I am going to try to unmute Deborah Murr on the phone. Deborah, are you hooked up to the phone? It doesn't seem to be working. Deborah, if you want to go ahead and type your question into the question box. It didn't seem to work when I unmuted your line. So let's see if there are other raised hands or questions that have come in. All right, we've got a couple questions in the question box. So one question, I think this, you may have mentioned this, but to reiterate, for your virtual visits, which application or software do you use?
Yeah, so we use Vidyo, V-I-D-Y-O, which is a HIPAA secure software, and we have a license for one room, which we all can share and enter, and you can go into that room just like you saw me with my team or with my patients, and we can lock the door in that virtual room. And again, that's happening on people's smartphones. So there's no extra technology required. It's just simply a smartphone. People can use Zoom or Skype for Business. Those are also HIPAA secure. The beauty clunkiness right now with this technology is that it does require someone on the user end, the patient end, to download either an app on their smartphone or something on their laptop. They obviously need a camera on their laptop or their phone. And so for elderly people, it's definitely much harder. I do have patients where I will try to invite them. They can't figure out the download, and they'll just want to send me a picture by email of what they're worried about. The 99-year-old who spilled coffee all over her legs, and the daughter wants me to see the legs and just can't figure out how to download this. But most people, especially when our nurses go into the home, if they download the video app onto the smartphone for the patient or the home health aide, once people have it, they love it because it's very easy to just send someone an invitation by text or email to join you in your room, and then they just pop in, very much like FaceTime or Skype, although this is HIPAA secure, so it works very well. I have spoken to folks who are actually buying smartphones for a Medicaid population, and they own the phone. And because they own the phone, they are able to use FaceTime, and they're also able to kill the phone. If the patient goes missing or whatever, the phone would have no value because it could be terminated. So that's sort of interesting because FaceTime is very easy to use, and people are a little more familiar with it. But you can't use that. It's not secure enough when people have other things and they own their own phone and so on. So it has to be something that's HIPAA secure.
Thank you. Okay, we have a number of questions lined up here, so we'll run through them. So one is, do you see any Medicaid patients? And if so, how is caring for this population different? Have you had to modify the model?
Yeah, we do have some Medicaid patients, and we're in Queens, Nassau, and Suffolk County in New York. So in Queens, we certainly have a number of Medicaid patients. It's certainly more challenging. Even just reaching people, the social factors that we're finding in the home, the inability to just go privately hire, obviously, a home health aide, which is what many of our patients actually need and just can't afford it, and the burden on family members who are caring for children and working. We do increase our touches to higher needs patients. We also send our volunteers more often to those homes for checking in because many are just so isolated socially. And that is where we beef up our support of just extra touches and phone calls. And so some of those patients we would put also on our secretary's call list where she'll call once or twice a week just to check in because they are so socially isolated and may have no one else checking in on them. So we try to do what we can in the scope of that. And then, some of the patients, too, without a smartphone or ability to connect with us. And that is where it may make sense to purchase a smartphone, even just to give them the ability to connect with us when things aren't going well, so that they could reach us and we could, help manage all of their issues with them.
Great, thank you. Another comment and question. Comment was great presentation. And the question is, how do you choose a comparable group for measuring outcomes? It's always a concern that those who choose palliative care programs are different than those who do not.
Such a great question and really spot on. We're actually in the process now of writing up our data, and getting a matched control group is really important. So one of the things that I showed on this slide, one of the ways to control for it on this slide is the fact that all of the patients in the gray line, which would have been our control group, died. They all died during the same period of time. They all died in the same counties. The mean median ages were the same. We're actually looking at Charleston Comorbidity Index between the two groups, which was the same. It was 8 between the groups. So we're starting to look to see whether other things match up. But you're really correct. In an academic sense, purely academic, we would want to prospectively stratify two groups, one to get palliative care and one not to, based on a propensity-matched control group so that they have the same disease burden, age, live in the same spot, and all of that. So we did this data retrospectively, but going forward, we may try to see if we can do that. But we did control in this slide here that I'm showing you for variables that we could. So they all died in the same counties. Age was matched, and it does turn out that the disease burden was the same in both groups. people aren't really choosing palliative care. Just to be clear, we don't brand ourselves as a palliative care program. We don't get stuck in that nomenclature. So when we call, we'll say that we're calling from ProHealth, Dr. Cohen's office, and he was worried about you, and could we send a nurse to see you? We noticed you were in the hospital twice this past month. And honestly, the usual response is, oh my God, Dr. Cohen is so smart. I can't believe he thought of that program. There's just what we need. We can't get to his office. It's too hard. My daughter works. So most people really like having a nurse come to the house. We don't get stuck in them having to choose this. They get very upset when we disenroll them, actually.
Well, so this isn't a question that came in, but I had some questions about that, the whole disenrollment process. What is the kind of maybe level setting or preparation you do with folks up front to help them understand what the program is and isn't in terms of preparing for possible disenrollment, or is that something you just deal with when it comes up?
Yeah, and again, we don't disenroll that many patients, maybe
right.
5 or 10%.
Yep.
But what we say is that we're an extra layer of support at home, and we're going to work with all of your other specialists, or boy, we noticed you don't have any doctor helping to coordinate your care, and you've been in the hospital 3 times in the past 6 months. That must be really hard. How can we help support you at home? Can we send doctors and nurses to your house to help take care of you better so you don't have to keep going to the ER on Saturdays? And people really respond to that. They really like that. And they also can't believe that when they call at 6 p.m., a physician actually answers the phone, and we listen to what's going on, and we come up with a plan. And if we have to, we'll do a virtual visit, or we'll have one of our nurses first thing the next morning at 8 a.m. see that patient first. Our nurses are really superb. I will say that the calls that we get at off hours are usually anticipated because the nurses have done such a good job making sure that they know their patients, that we have a contingency plan for progressive shortness of breath or weight gain for heart failure or other things that might occur, so that the nurses really, especially during the one-to-one, make sure all of the medications are in the home that we would need and that there's a plan for everything. We also do make sure that there's a pulse or a MOLST in the home at the right time. So we use that form to document preferences for DNR and hospital admissions. So we fill out just those 2 boxes, the DNR and don't hospitalize if those are their preferences, and we leave that form in the home in a white envelope on the fridge. So we have that conversation at the right time and make those wishes known so that if someone does begin to die at home and they're not in a hospice program, we don't have to panic. We've got everything we need at home, and we can just continue to care for them.
Great, thank you. So there was a follow-up question to the issue around assessing impact and the comparison group issue. So harkening back to that question, do the payers that you're working with require a certain level of evidence, or are the payers convinced with the kind of outcomes that you're showing them at this point?
Yeah, so we have, with our PMPM now, we use their propensity score, which is actually quite good, with our clinical screening tool. And we have started to compare the spend in those that have died with our program compared to their usual care controls. And they have found a significant savings and, in fact, do not allow us to disenroll anyone based on what their actuaries have calculated to be the savings. So in that particular program, we actually are not allowed to even disenroll because there's even a savings for those that are not dying in terms of reduced ER visits and hospital admits per 1,000. So they track that compared to usual care and have found significant value and just renewed us for another year, actually.
Mm-hmm. Great. All right, there's a number of additional questions, so I'll keep running through them. So here's a question of how do you interact with the patient's primary doctor and subspecialist? And also, secondary question from the same person, do you prescribe medications and other treatments?
Yeah, it's a great question. So absolutely, we prescribe all needed medications. We renew anything. We talk with lots of docs, many of them not part of ProHealth. Many of these patients have doctors in the city or at Sloan Kettering or Mount Sinai or NYU. We speak to all of their other docs that are still involved. We loop back with their primary care doc, although very often the primary care doc maybe hasn't seen them in a while because they're getting so sick or they're going to the ER so often or hospital so often, so that there really isn't a captain of the ship. But we do try very hard to keep them informed. So we have 4 standard emails as well that go out to all primary care docs, so that we send out an email that we've identified their patient as a high risk. Please let us know if they prefer we not enroll them in ProHEALTH Care Support. And if we don't hear back, it's an opt-out, they're automatically enrolled in our program within 24 hours. So it's an opt-out. We then send them an email if we transition the patient to hospice, and then we'll send them an email if the patient has died. So those are the 3 automated emails that go out to all primary care docs, whether they're involved or not in the patient. And then there are many other calls, either from me or my other docs, to the other involved physicians, just to try to over-communicate. And we still slip up. There's sometimes a cardiologist that we just didn't know was connected to this patient for 40 years, and we just didn't know, but we reached the other 2 doctors. So it happens that we miss someone because the family just didn't tell us about that doc or something, but we try very hard to stay in touch with the patient's many other providers.
Great, thank you. So here's a question, I think, following up on the when you mentioned your nurses. Is there special certification or training that your nurses have?
Yeah, some are hospice and palliative care certified. Others came from an ICU background, actually. And again, we're not a home health agency or a hospice. We're really a large physician group, so they're really an extension of the physician practice. We're not billing on these visits under the home health benefit or any other benefit. It's part of our ACO, and it's a service that we actually only offer to ProHealth patients. So we're not offering this service to other patients in the area. We don't go looking to give this out. We do this within our ACO and shared savings programs, or for this other health plan with the PMPM. But they are all really superb in their role. They love their role. They love the autonomy of having a panel of 85 or 90 patients that are their own, and they sort of feel like they're CEO of their own company. I will say at team meeting, though, we do, it's very clear what the metrics of success are for each nurse. So we do review every single hospital admission and ER visit, each team meeting, and we vote during the team meeting. The nurse will present her patient that got admitted. So with a census of 600, we might have 5 admits each week to review, and the nurse will present what happened, when she last saw the patients, when he last made a phone call to the patient, when the contacts were and what was going on. And the team will actually vote as to whether we think that was an avoidable admission. And then we track those and we learn from them. So that if somebody was febrile and we prescribed an antibiotic on Monday, but there was no call Monday afternoon, Tuesday, Wednesday to see how the patient was doing, and they subsequently got admitted Thursday, that's an avoidable admit in our book. And so we would want to go back and see why wasn't there follow-up, what broke down in our process that we failed to follow up correctly.
All right, some additional questions here. How do patients feel when you transfer them to hospice? Do you continue to follow them or stay in touch?
So we have superb relationships with 3 big hospices here, and we make the recommendation that the family will get much more care and support with hospice. It's a benefit they're entitled to, and this is who we partner with at this phase of the illness. We almost don't present it as a choice, and we refer over to hospice. We certify, but we do not continue to follow, although sometimes when we've made close connections, our nurses will continue to just socially stay connected and support the family through telephone calls and maybe even drop by just to see how families are doing. But we have a very high hospice. Once we make the referral to hospice, their MOLST is completed already. Everything is they're eligible. There's really never a glitch because we want them to get more of the care that hospice can provide. 24/7 availability of nurses, for example.
Do you ever get calls from people trying to self-refer to your program?
Yes, we get a lot of self-refer, and we get a lot of doctors now wanting to refer their parents, which actually is great. So we love it when our docs want their parents in our program, and we make an exception, in fact, and we take all of those because we feel that we are going to educate a workforce about palliative care who probably don't know much about it. So we think there's huge value in doing that. And when people self-refer, if they're really in our region and it's convenient, and if we really feel they're very appropriate for our program, we will do it on a case-by-case basis. But there's obviously no way to bill for that. It's really only if they're very closely living near other people that we're already seeing and that they're very appropriate. Also, we have a lot of what we call one-and-dones where they really belong in a hospice program. They're eligible. They would get much more appropriate care in hospice, much more intensive care. And so we will have that conversation. I'll often just do that myself on the telephone without sending anyone there and just make that transition right to hospice on the telephone and send over the records from the primary care doc's office or help the other doctors make that transition because perhaps they weren't comfortable having that hospice conversation.
Mm-hmm. Thank you. Here's a question. How do you like the telehealth visits compared to clinic or home visits?
I love the telemedicine visits. I really like seeing what's going on. I like seeing the environment that the patient is in, the environmental scan that my nurses will do for me. They know that I like to see what's in the fridge. I want to see the bathroom. I want to see where the patient's room is compared to the rest of the house. I want to see if there's a hoarding situation going on, or I just like to see the environment that folks are living in. It just gives me such a clear picture that words don't, so I remember the patient better. So when I've seen patients using telemedicine and then they might call at an off hour and I'm on call, I have a very clear picture of exactly what's going on because I have a visual of that patient. I also feel more confident in what I can recommend by seeing certain things on the skin or a wound or a cellulitis or how someone is breathing. And I am more comfortable managing something with telemedicine or telephone by having that combination. So it's just, as opposed to having to refer to one of our ProHealth urgent cares, I can actually just follow visually with the patient and family. I also think the family members, especially those living far away, really like being able to be included in some of the family meetings that we have. They like to be included. They feel like they can see everything that's going on. I just did a family meeting on Memorial Day with six adult children. One was living in Chicago, and so we were able to include the son that way, even though he couldn't be in New York. And it just really made him feel a part of the conversation.
So you just kind of mentioned Memorial Day, and there was a question here of, do you or your nurses do unplanned home visits on weekends or holidays?
Generally not, and that is where we tend to use more of the telemedicine. So again, we're not staffed for night visits or weekends or holidays, and that is why, since there's a payment stream for hospice, we do refer patients to hospice who we think are going to need those kind of services. They're going to be very symptomatic at nights or weekends or need really extra support. We can really strongly recommend that we make that transition to hospice because they'll just get more boots on the ground availability.
Okay, we have a few minutes left and a few more questions that are listed here, but if anyone still has a question, feel free to type it in. We'll try to get to it. So here's a question or request. Please say a bit more about recruiting volunteers, especially Reiki practitioners.
Yeah, so all of our nurses, we try to geomap the regions that our patients are in around where our nurses live. So that's one of the things we try to do since our ACO is so huge and there's so much need, we actually can select which regions we're going to. So our nurses know a lot of the community folks as well as our docs. So we through the community temples and churches, there are volunteers through that. And then we have college students that want to work at ProHealth during the summer. And this is one of the places where they are offered a position. So we'll have college students during the summer. But many of the folks from the communities work. They want more meaning in their life. They just want to do something meaningful that they can do on their own time. And they develop very close relationships with patients. We have a 103-year-old woman who lives alone with a private hire home health aide. And she reads, and she was always reading the stroke guidelines. And she'd call me up, Dana, I think I'm having a stroke. So we got her a Reiki therapist who would go to see her once a week. We took away the stroke guidelines, and we gave her a new book. We gave her 50 Shades of Grey, actually, I think was what the home health aide gave her. And she read all 3 books, and I didn't get any more calls from her. about having a stroke, and she connected incredibly well with our Reiki therapist and was not at all into Reiki, but seemed to really like these visits and this connection. And the volunteer just loves this lady because, it's just such a privilege to get to be with someone with this life experience.
Okay, we still have a couple more questions. I'm going to try to run through them. Do patients who you have referred to hospice ever graduate from hospice and return back to your program?
Yeah, and especially some of our dementia patients, and so we're very clear with our hospice partners that and we're grateful for them to take a patient that's somewhat borderline, but we're very worried about them. They will take those patients, and if after a certain point they really aren't hospice eligible, they will transition immediately back into our program so that it's seamless. And that doesn't happen very often, but occasionally with our dementia population it does. So we're waiting with open arms to take those patients back.
Great. And someone just asked about the PowerPoints. Yes, we will be providing the slides as well as a recording of the webinar, so you'll be getting that by email. I think this is a good question to wrap up on because we just have 2 minutes left. Thinking of where you are now versus where things were 3 years ago for your program, what do you know now that you wish you'd known back when you were just starting?
I think 2 things. I think I would have hired a data analyst sooner. I just hired one this past few months to help me sort through the Medicare claims data to really find the sick people. And so hiring somebody who could really manage that to case find the sick people is extremely useful. And so I think we've got that down now, but that would have been helpful at the beginning. And the second thing is really the infrastructure. I came from an inpatient ICU and then ultimately palliative care background from a hospital. I was in a hospital for 20 years, very new to outpatient home-based care. So just started hiring nurses and started seeing patients, but did not build the infrastructure within my department to support rapid growth. So we grew really quickly, really fast, and I should have probably hired more secretaries and program managers from the get-go. I didn't really even think about that part. We just got a patient list and started seeing patients, and off we went. So building the infrastructure and hiring a data analyst earlier.
Great. Well, thank you so much. This has obviously been very, very helpful to teams. Lots of great questions and comments. So I appreciate your time so much and for being with us today and sharing your wisdom. So thanks so much, and this concludes our webinar for today.
Terrific. Thank you.
Thank you. Thank you.